The standard of care for triple-negative breast cancer for years had been progressively increasingly aggressive combinations of chemotherapy because triple-negative breast cancers are marked by genomic instability, a high tumor mutation burden that made them vulnerable to chemotherapy. We recognized that combination also made them immunogenic, and so there was always recognition. Over time, we came to appreciate that when you see the immune system in there, or there's immune lymphocytes in the tumor, those patients seem to do better even in the absence of drug therapy. And with drug therapy, they do better still. So there's always been a sense of the immune system is seeing it, but it's not taking care of it. So the excitement of drugs like Atezolizumab and the drug that's actually approved in the indication, pembrolizumab, has always been that it appears these drugs should address the normal mechanisms that the body has to prevent overactive immune responses in the PD-1 and the PD-L1 proteins on the surface of cancer cells. We've learned that that interaction can inactivate immune T cells that can't eliminate the cancer. So the whole thing with the checkpoint inhibitors was, okay, great, our chemotherapy is effective at reducing the burden of cancer, and sometimes it's curative, but maybe if we can augment the immune system, we'll get a better result. So that's basically the basis, the rationale for the NSABP B59 GeparDouze trial. Our study began without incorporating PD-L1 status as a stratification variable. We had always planned on evaluating that and correlating it with endpoints, but when we began, we didn't yet have all the information from the metastatic trials, from the neoadjuvant studies, suggesting that it could be differentiating. So in our study, we amended it to actually make that a requirement. We have PD-L1 information on everybody, but some of it was done after the fact. Bottom line though, on our study, and this is similar to what's been seen in other neoadjuvant studies, the PD-L1 status did not differentiate between the two, which is very different from metastatic. And it's probably related to the fact that it's a very dynamic marker, and when you get into an existing tumor and attack it with chemotherapy, there's undoubtedly changes that are going on that probably relate to why that doesn't seem to be a differentiating factor in neoadjuvant therapy. The findings from our study were really not appreciably different from what had been seen in other metastatic trials or what's been published from the Keynote 522 study. The most common immune toxicities were related to the thyroid, hyperthyroidism or hypothyroidism. And you do see it in our data. The placebo arm has patients where since the doctors were blinded, they were always asked, is this event likely immune related? And that's one of the advantages of a placebo-controlled study. You can really get a sense of what's the incremental increase. Then there were the host of the serious things. We had some patients develop adrenal insufficiency, colitis, but they are thankfully rare, but they continue to be one of the concerns with the agents, that there is that potential risk. Yeah, one of the differences between our study and the Keynote 522 study was they completed their accrual very rapidly. They had a smaller sample size and it was a global study, so they finished in like 19 months. They had their first patient in 9 months before we did, and they finished in 19. It took us 41 months working with basically the footprint in Germany and US and Canada, as well as Spain towards the end. So what happened during that time period is they were basically finished with their patients in treatment on their protocol before the CREATE-X trial showed us that capecitabine could help patients who had non-PCR. We were still treating patients, so when that result was out, we had to amend our protocol to allow it. So about half of our patients who did not have a complete pathologic response, actually in both arms, received capecitabine. There are a number of differences between the trials. That's one of them. Olaparib got approved very, very late, and that was, you have to have germline BRCA pathogenic variants to get olaparib, and we only about 8% of our patients had that, so very few patients received olaparib. We believe that our therapies are incrementally reducing residual risk, so we kind of knew that that potentially would cause fewer patients to recur, which is obviously a good thing for patients, but in terms of study design and outcome, that's part of why we had to wait a longer period of time before we had enough events to analyze, as opposed to the Keynote studies. At this point, fortunately, the survival on our study is remarkably good. I mean, patients in both arms were about 90%, had a 4-year overall survival of 90%. Very, very little difference at all. So we don't expect that we're ever going to see a survival benefit based on where we are. So I mean, this is why, you know, we can't claim that atezolizumab is effective at all. So it's not going to, results of our study aren't going to alter standard of care. What we're hopeful for is when we looked at our study, we had a surprising amount of heterogeneity amongst our stratification factors. Like when we couldn't see any evidence, a suggestion of benefit if patients were node negative or had small tumors. Patients who were node positive at presentation or had larger tumors or had a high percentage of those TILs I spoke about earlier look like they may be getting benefit from it. So there's a heterogeneity component in our study that I guess it's a silver lining for us a little bit. I mean, the study, again, we can't claim it's positive, but it is something that I think translational work to look to see, can we find biomarkers that tell us who's more likely to benefit from this class of drugs may still prove useful. So we're going to be working on that pretty intensely over the next couple years.